If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In this episode, we'll go through the NICE recommendations on the drug treatment of type 2 diabetes included in the NICE guideline NG28. The link to it is in the episode description. In today's episode, we're focusing on glucose-lowering treatment options if further interventions are needed after first-line treatment. If you haven't already, I'll recommend that you check the previous episode on the first-line drug management of type 2 diabetes. Right, let's jump into it. So we're going to look at the treatment options if further intervention is needed, basically what to do after first-line treatment. But first, let's talk about reviewing drug treatments and when we will need to add an SGLT2 inhibitor at any point after starting first-line therapy. For adults with type 2 diabetes, no matter where they are in the treatment journey, if they have or developed chronic heart failure, established atherosclerotic cardiovascular disease, or become at high risk of it, if they're not already on it, we should offer an SGLT2 inhibitor that has proven cardiovascular benefits. This can be added onto the current treatment or used to replace an existing medication. And let's remember that this is because there is strong evidence in large randomized controlled trials that has shown that SGLT2 inhibitors not only improve blood glucose control, but also reduce the risk of hospitalization for heart failure and in some cases lower cardiovascular mortality. These benefits are seen even in patients without diabetes, which highlights their role in protecting the cardiovascular system as well as the kidneys. Right, now before we look onto how to intensify treatment, let's quickly cover what NICE says about monitoring and HbA1c targets. Regarding diabetes monitoring, NICE recommends measuring HbA1c every 3 to 6 months until it's stable on unchanging treatment. After that, once HbA1c is fully stable, measuring every 6 months is usually enough. When it comes to HbA1c targets, we should discuss and agree on an individual goal for each patient. The aim is to help them reach and maintain that target, unless trying to do so causes problems like hypoglycemia or lowers their quality of life. Generally speaking, for those managing their diabetes with lifestyle changes or a single drug that doesn't cause hypoglycemia, the target is around 48 millimole per mole or 6.5%. For patients on medications that do carry a risk of hypoglycemia, the target is a bit higher, around 53 or 7%. If an adult's HbA1c isn't controlled by a single drug and rises to 58 millimole per mole or 7.5 or above, then we need to review and reinforce the current treatment, and after that we usually move to intensifying drug treatment by adding a second medication. Now let's look at treatment options when further intervention is needed. For adults with type 2 diabetes, if monotherapy isn't enough to keep HbA1c below the individual target, we can consider adding one of the following: a DPP4 inhibitor, pioglitazone, a sulfonylurea, or an SGLT2 inhibitor. If dual therapy, usually metformin plus another drug, isn't controlling HbA1c below the agreed threshold, then we have two main options. We can either move to triple therapy by adding a DPP4 inhibitor, pioglitazone, a sulfonylurea, or an SGLT2 inhibitor, or we can consider starting insulin. In adults with type 2 diabetes, if metformin is contraindicated or not tolerated, and dual therapy with two oral drugs still isn't keeping the HbA1c below the agreed threshold, then insulin should be considered. This essentially means that triple therapy is only recommended by NICE when one of those three drugs is metformin, not otherwise. If triple therapy with metformin and two other drugs isn't effective, isn't tolerated, or is contraindicated, we may consider switching one of those drugs for a GLP-1 mimetic. But according to NICE, this is only for adults who have a BMI of 35 or higher, with adjustment for people of Black, Asian, and other minority ethnic groups, by reducing the BMI by 2.5 to 32.5. And who also has specific psychological or medical problems linked to obesity. or if they have a BMI under 35, but for whom insulin would have a significant occupational impact, or where weight loss would help other serious obesity-related health issues. GLP-1 mimetic therapy should only be continued if the patient shows a clear benefit, that is, a drop in HbA1c of at least 11 millimole per mole or 1%, and a weight loss of at least 3% of the starting body weight within 6 months. Also, we need to be aware that combining a GLP-1 mimetic with insulin should only be done under specialist care and advice. So, as we have just seen, NICE recommends using GLP-1 mimetics mainly for people with type 2 diabetes who have a higher BMI or specific obesity-related problems. They also set clear criteria for continuing treatment based on how well the patient responds metabolically and whether they lose enough weight. Now, we should also point out that other guidelines, like those from the American Diabetes Association or the European Association for the Study of Diabetes, take a fairly different approach. They suggest considering GLP-1 receptor agonists earlier in the treatment journey, especially for patients who already have cardiovascular disease or are at high risk of developing it, no matter the BMI. These other guidelines focus more on the cardiovascular benefits of GLP-1 therapies, in addition to blood glucose control. So, while NICE tends to emphasize weight and BMI, the American Diabetic Association and the European Association for the Study of Diabetes put more weight on cardiovascular risk when they recommend GLP-1 receptor agonists. This is because research has shown that GLP-1 receptor agonists can reduce the risk of major cardiovascular events in people with type 2 diabetes who either have established cardiovascular disease or are at high risk of it. For example, the LEADER trial looked at liraglutide and the SUSTAIN-6 trial studied semaglutide. Both showed significant reductions in cardiovascular events compared to placebo. Next, let's move on to insulin-based treatments for adults with type 2 diabetes. When starting insulin therapy, we're likely to continue offering metformin, provided there are no contraindications or intolerance. At the same time, we should review whether other blood glucose lowering medications are still needed. For insulin options, we have several choices. The first-line option for NICE is NPH insulin, which can be given once or twice daily depending on the person's needs. A quick note about NPH insulin: it's an intermediate-acting insulin with an onset of action around 1 to 2 hours after injection. Its peak effect usually occurs between 4 to 8 hours, and it lasts for about 12 to 16 hours. Because of this profile, it's useful for covering blood sugar levels between meals and overnight. We should consider starting both NPH and short-acting insulin, particularly if a person's HbA1c is 75 or 9% or higher. This can be administered either separately or as a pre-mixed or biphasic human insulin preparation. However, NICE also suggests that we can consider using insulin detamir or insulin glargine as alternatives to NPH insulin in certain situations. For example, if a person needs help with injections, if they experience recurrent symptomatic hypoglycemia, or if they would otherwise need twice daily NPH insulin injections along with other medications. And now a quick note of insulin detamir and glargine. Insulin glargine is a long-acting basal insulin that provides a steady release over 24 hours with no pronounced peak, which helps maintain more stable blood sugar levels throughout the day and night. Insulin detamir is also a long-acting insulin, but usually has a slightly shorter duration, lasting about 16 to 20 hours. It tends to have a mild peak and may require twice daily dosing in some people to maintain adequate coverage. Both glargine and detamir offer a more predictable action profile than NPH insulin, which can help reduce the risk of hyperglycemia and improve blood glucose control. When it comes to pre-mixed or biphasic insulin preparations, NICE recommends considering short-acting insulin analogs rather than short-acting human insulin, particularly if the person prefers injecting insulin just before a meal, if hyperglycemia is a concern, or if the blood glucose levels spike significantly after eating. This is because short-acting analog insulins are rapid-acting insulin designed to manage the blood sugar spikes that happen around meal times. They start working fast, usually within 10 to 20 minutes, peak at around 1 to 3 hours, and their effects last for about 3 to 5 hours. Because of this quick action and shorter duration, they can be injected right before or just after eating, offering more flexibility. Common examples include insulin lispro, insulin aspart, and insulin glulicin. One key advantage of these analogues over regular human insulin is a lower risk of hypoglycemia, especially overnight or between meals. The rapid onset and shorter duration means that insulin levels drop off sooner, reducing the chance of blood sugar dipping too low when it's not needed. Finally, if someone is already on an NPH insulin, we should also consider switching from NPH insulin to a long-acting analog like insulin detemir or insulin glargine if they experience significant hypoglycemia while using NPH insulin, they're unable to use the device required for NPH insulin, or they need help with injections, and switching to a long-acting insulin analog could reduce the number of daily injections needed. We will need to monitor patients on a basal insulin regimen, whether that's NPH, detemir, or glargine, for the possible need to add short-acting insulin before meals, or to switch to a pre-mixed biphasic insulin preparation. Similarly, adults on pre-mixed insulin should be regularly assessed to see if they need an additional injection of short-acting insulin before meals, or if the blood glucose control would benefit from moving to a basal bolus regimen with NPH, detemir, or glargine. This ongoing review helps ensure insulin therapy is tailored to achieve the best possible blood sugar control for each patient. So that is it, a review of the treatment options in type 2 diabetes if further interventions are needed after first-line treatment. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.